Okay, so any questions from the first pulmonology section? We covered pneumonia and kind of the infectious disease side of things. Everyone's pretty well versed in that. Fantastic. Okay, so we're going to continue on and talk about kind of our secondary portion. Focus a little bit on asthma. And so, have you guys covered this yet? At all?
Yes.
Okay, so you guys are familiar with it. All right, so obviously, so what is asthma? It's an allergic reaction, sure. What? Hyperreactivity of the smooth muscle in the bronchial tract there, right? So again, what's the key component of this though? Sure, eosinophils, but as far as this component, I guess you use a laser pointer. The reversibility of it, right? So this is a reversible thing. This is not something where you're having kind of long-standing damage being done. We'll see this is not the case when you get into like COPD. We're talking about emphysema, chronic bronchitis, things like that. So again, this is the key point here, is that we can reverse this. We have drugs that can help to prevent it from occurring in the first place. Obviously, you guys are familiar with some of the signs and symptoms associated with it: a lot of dyspnea, tachypnea, chest tightness, all this fun stuff. You can also end up seeing, because of this kind of allergic response we're having to whatever happens to be, and usually it's IgE-mediated sort of reactions that we're having here, having a lot of mast cells degranulating and causing these inflammatory cytokines all kind of circulate. You'll see that bronchial smooth muscle constriction. You also see a lot of bronchial mucosa kind of thickening. You'll see a lot of mucus production happening here. And certainly we know that the genetics are playing a large role in this occurring, but there's lots of other kind of modifiable things we can do with the patient, certainly to make these symptoms better for them, but there is a large genetic component. So we know this is a frequent occurrence for visits. When are people most likely to present to, like, say, the ER for an asthma exacerbation? Like time of year?
Spring.
Sometimes spring, it depends on, what like the pollen's kind of doing, but you see a lot in the wintertime months, right? Because again, sometimes things like cold air can even be a trigger for some people's asthma. A lot of times you'll see patients will get respiratory viruses that can trigger an asthma exacerbation for some of them. So again, you can see there's kind of, this wintertime months, we see a lot of respiratory complaints. I'm seeing a lot of patients show up to the ER for that. So we're starting to see some of those spikes. For us, we're starting to see more flu tests being run. You're starting to see a lot more albuterol treatments being ordered, different things like that. They kind of signify, hey, winter's here, time to get your flu shot, bring our Santa hats in, and everyone's coming in getting albuterol, essentially. But a lot of deaths associated with this. And when we find these pathological findings for these patients who have died, you see pretty constricted smooth muscle in the airway. You're going to have this mucosal thickening, a lot of cellular infiltration, and then these mucus plugs that are blocking the smaller airway. So we're going to use multiple mechanisms to try to target kind of each of these steps here. And the primary thing with treatment of asthma is there's kind of two kind of modalities of therapy. We have our rescue therapy, which are going to be able to fix kind of our acute asthma exacerbations. Then what else can we have? Really like chronic maintenance, right? So we're going to try to prevent asthma exacerbations from happening in the first place. And so this is going to be a little bit similar to what we saw with like our medication for rhinitis, how we're trying to deal with that inflammation before it ever becomes a problem in the first place. So again, corticosteroids we're going to see here are going to be important. So obviously you have kind of covered the symptoms a little bit. And again, this is really a means of inflammation happening here. You're having a hypersensitivity to some sort of allergen or some sort of trigger. It's causing this airway obstruction and this hyperresponsiveness. And this is where you kind of get the clinical symptoms that we're kind of familiar with. So looking at the components here of this kind of inflammatory cascade, this is important to point this out because this is where a lot of these medications are going to be coming into play via these different mechanisms. Obviously, when allergen is going to come along, we have things like IgE that are helping to mediate these reactions, right? So with these hypersensitivities, you're going to have these mast cells that are degranulating and they're releasing all sorts of things like prostaglandins, leukotrienes, platelet activating factor. Histamine is also going to be another big player here, right? Just like we've seen with other kind of allergic conditions. And so we're going to see that, we're going to have medications that work kind of on different components of this pathway in order to either reverse kind of the acute effects we're seeing once that reaction is occurring, or we can have things that will kind of prevent these mediators from being released in the first place. So when you have an asthmatic exacerbation, basically you're going to see there's kind of this bimodal kind of peak. Have you guys kind of talked about this before? So you have the kind of the acute exacerbation, which will be kind of over the first hour or so. It's kind of the early reaction where you get a lot of smooth muscle contraction. This is where a lot of your mast cells are degranulating. What you end up seeing, though, this is kind of this late phase kind of reaction that happens here several hours after the fact. And again, this is measuring FEV1, which, what is that?
Forced expiratory volume.
Yeah, forced expiratory volume over
1 minute.
1 second, right? I can't really breathe out over a minute. That'd be really tough to do. I'd be trying pretty hard. But over 1 second though, and again, that makes sense because if we're having bronchial smooth muscle contraction, that makes it harder for us to expel air, right? Even if the pressures are very high, caused by the diaphragm, the intercostal muscles, and all that stuff, even the squeezing down, it's harder to push that air out. So that's why we measure our FEV1. That's kind of the first thing that takes a hit during exacerbation. So you can see here early on, during the first hour or so, it's going to drop down pretty significantly, again between 100 and say 75% of what the normal would be for that patient. And then several hours later, you're going to see this happen again. A lot of times, if you treat just the early phase of this, patient feels better, they go home, all of a sudden they're going to have the second phase reaction, and it's going to be more difficult to treat. And then patients, if they die, it typically is going to be happening in this kind of later phase, that or they never sought care for the initial cause here. But we'll look at some of the ways we can help to prevent this from occurring for our patients. Again, looking at the allergen coming along, activating a lot of our T cells. We have the cytokine productions happening here. Again, a lot of eosinophil involvement happening here with asthma. Again, having a lot of our mast cells degranulating here, and this is where you're going to get the smooth muscle contraction. Also, these little mucus plugs are going to be starting to form here as well. This edema that's happening. So all these kind of typical allergic reactions just happening kind of within this enclosed space. And again, if you're blocking up airways with these little mucus plugs, guess what? There's no air exchange happening there as well. So this is another important pathway to note here is that we talked about the inflammation pathway. We talked about how arachidonic acid is one of the kind of the first precursors here. There's a phospholipase enzyme that will come along and kind of free this from the cell membrane. And then it's going to lead over into one pathway that would be cyclooxygenase, right, or COX enzymes. And you remember what drugs are preventing this from working? NSAIDs, yeah. So like ibuprofen, naproxen. We'll talk more about other NSAIDs later on, but that's going to inhibit the prostaglandin pathway. On the other hand, you're going to have this 5-lipoxygenase pathway, and this is where we get a lot of leukotrienes being formed here. So you see LTA. These are standing for different types of leukotrienes, and basically these are going to be kind of very important for this pathogenesis of asthma. When you have this pathway being more expressed, you're going to see a lot more of that kind of bronchial smooth muscle, kind of hyperreactivity. And so again, we're going to find another set of drugs that are working along this pathway here. Again, note the enzyme, instead of being a cyclooxygenase, you have a 5-lipoxygenase. So that's the different enzyme that'll you'll end up seeing this issue here. And I remember someone asking a question before, but if you ever see someone who has, say, like an NSAID allergy, they have an ibuprofen allergy, and they say they have an asthma attack because of that, this is actually, you can think about it via this kind of pathway. Because again, if you have someone who's taking a cyclooxygenase inhibitor, right? So you guys remember how, you can kind of balance out the side of a reaction. Well, if I inhibit this side, where do you think all this arachidonic acid is going to be going? Which pathway is it going to go down preferentially? Right, the lipoxygenase pathway. You're going to get a lot more leukotrienes. You're going to get a lot more bronchial smooth muscle constriction, and that's going to induce an asthma attack. Right, so some of these things you can kind of make sense of, and you kind of go back to the actual pathways and all of that. So again, remember these mechanisms. So looking at this pathogenesis, mentioned allergens are promoting IgE production. These antibodies are going to bind to the mast cells unless you're going to have airway mucosa starting to be affected here, right? Mentioned lots of inflammatory mediators, histamine being a really big one, leukotrienes, and prostaglandin as well. Those are going to be our major components here we're going to be focusing on. Right, this early asthmatic response is where we're going to start to see that not only do you have the smooth muscle constricting, but you also have vascular leakage, right? So that's also going to lead to some edema happening there, some more narrowing of the airway. And then you'll have this kind of more sustained kind of late phase reaction that happens about 3 to 6 hours later. And again, this is going to be caused by a lot of these cytokines produced by a lot of these lymphocytes, this kind of T helper lymphocytes, and then this is where you're attracting a lot of eosinophils. You get a lot more IgE and mucus production. Okay. Some other causes. So certainly you can't think of any other reasons for an asthma attack. I mentioned a few of them already. Illness, so like especially respiratory viruses tend to be a major cause for some asthma exacerbations. Anything else? Environmental cause, so like pollen in the air. So you might think like springtime asthma exacerbations. Yeah, so you can have exercise-induced asthma. That's important, right? Because some of these things are going to be kind of persistent causes for asthma exacerbations, right? Some of them are going to be seasonal. Some of them are going to be specific activity-induced, and that's important to recognize so that way you can treat your patient effectively. Someone who only has asthma attacks when they exercise, they're not going to need the same kind of therapy as someone who has kind of chronic, year-round, kind of persistent asthma. Okay, so those are important characteristics to take in mind. What else? GERD, yes, possible. Why would you think GERD would cause a reaction? So think about stomach acid, right? Stomach acid is very caustic. If it were to get up through the esophagus and you aspirate some of that into the airway, guess what? You're gonna have a kind of a hyperreactivity to that, right? This is tissue now that instead of a normal person who may be able to respond to that well, these are people who have really kind of hypersensitive kind of tissues here, right? They can't really take any kind of constructive feedback. They just shut down and they constrict really tight and they don't let any air in, right? Very, very hypersensitive. Anything else you guys think of? One big one for me. Oh, yes, ma'am. Not necessarily. There might be some people, there's a little bit of bleed over there, but this is more kind of IgE mediated rather than, and we'll talk about rheumatoid stuff, and Dr. O could probably talk to you even more exhaustively than I could about that, but I don't think you really see a ton of bleed over there necessarily. The other big thing, like, so they have specific triggers in a lot of cases. So like animal dander can be a really big one. So for instance, I kind of mentioned my history with asthma. You know, there was a time period where I had a girlfriend who had 2 cats, and guess what? Like, you know, sometimes you tell your patients, hey, avoid cats. But, you know, sometimes the heart wants what the heart wants, and so you have to deal with it. I'd make sure my controller medication is really in check before I ever would go over to see her. Right? So these are things where it's really important to, you know, take diaries, like let your patients, you know, figure out like what is specifically is triggering these asthma attacks, so you can kind of target those things, and if you can modify those, you can, right? So somebody might have told me, we'll just break up with her, and it's like, well, that's what I ended up doing. But regardless, my asthma improved. It was great.
Don't lie, she chose the cats.
She was terrible. I'm just kidding. No, she's fine. She's fine. Anywho, right, so you can see some other factors here that are leading to some of the release of these mediators here. Certainly, we're going to see that the parasympathetic nervous system is also going to play a role here, right? So again, the autonomic nervous system kind of rearing its ugly head again. You can see some of these neural and humoral pathways, and so what you can see is that things like substance P, these kind of tachykinins that are kind of sensitizing the muscle, can directly stimulate that contraction. You can also see things like acetylcholine activating muscarinic receptors can be important here as well, because we mentioned when you have muscarinic receptor activation, what does that do to secretions in the body? It's going to increase them, right? Same thing happens to the lungs. You're going to get more mucus production. So that's why if you ever see someone who like comes into the ER for an asthma exacerbation, they usually get something that works as a beta-2 agonist, and they'll also get what else? You guys know what the other drug they get? Albuterol, and they get, I've never heard of Atrovent. It's another one we're going to talk about as being a very common. It's an anticholinergic that helps kind of reverse this. We'll talk about those in more detail, but just so you can start to think about it. Okay. So again, it can be treated with drugs via different mechanisms in order to get kind of some synergy here. So the goals that we're going to be focusing on are try to reverse this bronchospasm. So these are going to be things like beta-2 agonists. These include things like ipratropium, which I'll mention as being a anticholinergic, and then also this really old school drug called theophylline. And then we're going to have things that can help to either remove the antigen or remove the trigger. So we have some mast cell stabilizers like cromolyn and metocromol. These don't get really used all that often. And then finally, we have things that are going to help us to control inflammation, right? So these help us to prevent exacerbations from happening in the first place, include things like our steroids and things like lipoxygenase inhibitors. Okay, so these are kind of the classes we're going to look at. It's important to know how these drugs are working to know when it's appropriate to use them. So one of the first things you can actually do to see if someone, you can try to diagnose someone with asthma. Certainly you can go off the symptomatology, and it's usually pretty clear if someone has asthma or not. But one of the things we can actually do, and we do this for some of our research kids over at Nemours, if we're trying to determine if they truly have asthma or not, we can actually give them something called methylcholine. And essentially it's a drug that activates those muscarinic receptors, and it tells us just how hypersensitive the person is to these kind of triggers. So for instance, if we were to give someone methylcholine and they have a 20% drop in their FEV1, right, so you kind of do a pre and a post, you would end up seeing that, yes, they would have this hyperreactivity. Yes, they're more likely to truly have asthma there. And again, that would just be something we give via a nebulizer. Have you talked about what a nebulizer is before? How would you describe it? It's a machine, hooks up to a little cup, right? And then it kind of vibrates at a very high frequency, and that vaporizes the drug essentially, right? So it kind of makes a fine mist for patients to inhale. So we would do that for this methylcholine. You inhale it. If it activates those muscarinic receptors and the patient happens to be hypersensitive, they would drop that FEV1, right? And then obviously you don't want to leave your patient like that, because that would be very upsetting to a patient to, like, hey, you gave me an asthma attack, you want to fix it? We'll give them a beta-2 agonist afterwards to kind of reverse it. So have you guys covered a chart similar to this previously? Okay, this is how you kind of categorize patients as far as what type of asthma they have. Notice that a lot of this is going to be based not only on pulmonary function tests, but you're also looking at symptomatology as well. So getting a good patient history is super important, making sure you're going to get the full story here. So you're looking at things like how often are they having symptoms? Are they having nighttime awakenings? And then how often are they using their short-acting beta-2 agonists? Back when I was a little kid, had asthma, I had no controller medication on board. I was not well controlled, and so I had my little blue inhaler. It was in my pocket all the time, and it was like I was carried around like an EpiPen almost, right? It's very, very important I had that on me because I was not very well controlled, and persistent asthma, it just pops up every once in a while, and I have to use it, right? So you're kind of documenting these things. You're looking for changes over time based on these types of symptoms along with their PFTs. So certainly you can have intermittent asthma, which would be very kind of infrequent, or you know it's going to be a certain trigger, or like things like exercise, or if you know if you're going to be around dogs or whatever happens to be, you're going to end up having symptoms, right? Versus more persistent asthma, which is going to be kind of a more chronic issue. Again, symptoms are going to be, obviously you can break it down into mild, moderate, severe, based on just how you know, how much they're having to use their inhaler, how often they're waking up in the middle of the night, things like that. Again, I'm not going to ask you specifically, you know, is this patient based on these symptoms, they mild, persistent, or intermittent? But I will say, hey, this person only has, you know, asthma exacerbations when they exercise. What's going to be the best therapy for them, right? And so it's important that when we look at the meds, you kind of know which situation you'd want to use one versus the other. Okay, so again, our goal here is to try to reduce that level of bronchial responsiveness in the long term, because again, if we can prevent an asthma exacerbation, it's always going to be better for your patient than having to treat an acute exacerbation, right? So we want to decrease that responsiveness, and this is going to be used with anti-inflammatory agents. The primary ones we're going to go with are going to be our inhaled corticosteroids. Okay, so it'd be a very similar list to what we saw with our nasal steroids. And what was the benefit of using nasal steroids versus like systemic? No systemic side effects, right? You may get some local side effects, and we'll see this is the same thing here. You limit the amount of systemic side effects you see, but you get nice localized effects when you inhale these drugs versus having to take like a pill orally. And then obviously by preventing or reversing acute bronchospasm, this is where we can try to hopefully avoid triggers if possible, or if not, then we're going to treat with short-term beta-2 agonists. So these are going to be our mainstays of therapy for a lot of these patients. Okay. So looking at breaking them down into either quick relief or more kind of long-term controller medications. Quick relief ones include our short-acting beta-2 agonists. This is where albuterol is going to fit into the role here. We'll have anticholinergics, and then our systemic corticosteroids. Occasionally when a patient comes in, especially if they come to the ER or something with a really significant acute exacerbation, sometimes we will go ahead and give them a oral corticosteroid or potentially IV, depending on how bad the asthma attack happens to be. And the benefit, what do you think the benefit of using oral systemic steroids are versus using like an inhaled steroid in that sort of setting? How long it takes to kick in, right? So what you're going to find with the inhaled corticosteroids, these are very good for long-term control because they take a while to work. As we'll see, it can take a few weeks before you really see full effects. With these oral or systemic steroids, you're going to end up seeing much quicker effects, usually within a few hours, okay? So in a lot of cases, these patients may end up being on, like, say, 5 days of prednisone, or say maybe 2 or 3 doses of dexamethasone, and that way we call this kind of pulse therapy. That way they get kind of a short course of systemic therapy. You kind of knock down that inflammatory reaction, and they can go back on their controller medication like normal. This is kind of the typical way things go. And then at long-term controller meds, we have our long-acting beta-2 agonists. So then these are going to be similar to albuterol, but these are going to be very long-acting. They're not going to be for quick relief because they don't really work really quickly, but they last a while. Of our inhaled corticosteroids, Leukotriene Modifiers, mast cell stabilizers, anti-IgE antibodies, and finally Methylxanthines, namely of which is going to be theophylline. Again, this is kind of going down in the order in which you would actually use these. So the most common ones are going to include your long-acting beta-2 agonists plus corticosteroids, going down with the least common therapies. Now, a lot of you guys are actually utilizing a methylxanthine right now. Does any of you know what substance you're consuming that has it? Coffee. What's in it?
Yeah.
So with theobromine is structurally similar. It's also a methylxanthine, but starts with the C. Caffeine, the only thing that's going to get you through PA school, right? That's why there's a PAC on the end of there. It's a qualifier. You have physicians assistant caffeinated, right? Just kidding. Right, so caffeine actually fits into the same category of methylxanthine. So you can actually see that back in the day, we used to use caffeine as an anti-asthmatic medication. And in fact, actually has some good effects on stimulating respiratory drive. So if you ever see like a little neonate in the NICU that we're giving caffeine to, that's usually to stimulate their respiratory drive. So if you ever drink a lot of Zip Fizz or something like that, and all of a sudden you're breathing faster, that's probably why it is. But yeah, theobromine, where do you find theobromine at? Chocolate, yeah. So chocolate actually has that in there. That's why dogs can't have it, because they can't process the theobromine. So, anywho. So going back to our beta-2 agonists, so the ways that these are going to be working, I'll show you a picture of this in just a second. But basically, it's going to be increasing the secondary messenger, the cyclic AMP, increasing activity there, and this is going to lead to a relaxation of that bronchial smooth muscle. Now, keep in mind, we talked about different types of beta receptors. Where do you primarily find beta-1? On the heart, right? So activation of beta-1 receptors does what to the heart? Increased chronotropy, inotropy, you're going to have a faster, harder beating heart, right? Beta-2 agonists, on the other hand, what does that typically do? Bronchodilation. What does it do on the blood vessels? Actually causes dilation, yeah. So remember, alpha-1 causes vasoconstriction on the vasculature. Beta-2 actually has some vasodilatory effects. So always think beta-2, think about smooth muscle relaxation in general. But the lungs are the primary thing we're focusing on here. Again, things like albuterol are going to be short-acting. They work very rapidly and last about 4 to 6 hours or so, versus long-acting meds are going to be lasting, say, 12 hours or more. The long-acting ones do not kick in very quickly, so that's the caveat. You cannot use a long-acting drug for a short, an acute asthma exacerbation. You have to use a short-acting one. So big side effects we're going to see with that. And again, this is a beta-2 agonist. It's selective for the beta-2 receptor. Why would it see increased heart rate? Yeah, you lose some selectivity, right? So if you get a big enough dose, you end up losing that selectivity, and you can see some bleed over, where it can actually activate beta-1 effects. It also activates some beta receptors on the skeletal muscle, and that's where you can also see that kind of tremulence from. So I mentioned being growing up as a fat asthmatic kid. And so whenever I had a really bad exacerbation, I'd have to end up using a nebulizer. And so the thing is, like, normally when people use like a short-acting beta-2 agonist, it's in what type of dosage form? Like a little inhaler, like a metered dose inhaler. So if you see like an MDI, that's what it means, a metered dose inhaler. The nice thing about that is it's metered dose. So you get a very explicit dose, usually like 90 micrograms. You just breathe it in, and that's all the drug that you're going to get there. Versus like a nebulizer has a huge amount of drug that you're putting into, say like 90 micrograms for a typical like spritz of an albuterol inhaler, versus I can put between 2.5 to 5 milligrams of drug. 90 micrograms versus 5 milligrams, right? Big difference. Putting that to a nebulizer cup, and then you're just kind of passively just breathing the stuff in, you get a huge dose. And so that's why you see a lot more side effects with patients in these nebulizers, because they're breathing so much of the stuff that you see bleed over, and it's not just hitting beta-2, it's hitting beta-1, you're having all these other side effects from it, right? So people who use nebulizers, typically they get very tremulous, they have tachycardia, they get a little anxious, things like that, due to that bleed over effect. So again, there's things we can do to prevent that, and we'll talk about those a little bit later. So if you imagine a beta-2 receptor here getting activated, or G protein, secondary messenger pathway, it's going to upregulate cyclic AMP and will start to inhibit this linking between the actin and the myosin and that smooth muscle, and then you're going to have relaxation of that muscle there. So you're going to have the airways open up, airflow is going to be a lot better, unless your patient can breathe much more easily. So the main ones we have in this category include albuterol. Does anyone know, if you had a patient, because again, we're in a travel center here in Orlando, if someone from, say, the UK came over and they were on albuterol inhalers, do you know what they would call it? Salbutamol. So if you ever hear salbutamol, that is albuterol. Again, it comes up more common than you might actually think when you actually get out there and practice. There's also another cousin to this called levalbuterol. And again, what's the relationship between these two? Yeah, one's the enantiomer of albuterol, right? So a lot of people say, well, Xopenex is better because it's, limits the side effects. I'm not going to get on a soapbox here and talk about that, but some people, they swear by their Xopenex. It really doesn't make that big of a difference. Really, if you just decrease your dose of albuterol, you kind of limit a lot of those side effects. But regardless, you may see people on that, and people like their Xopenex, they really like it, but it's really expensive, so we don't carry it at a lot of hospitals. Regardless, those are going to be your main short-acting agents. The main long-acting ones you're going to find, and what's interesting, if you look at the literature, they tried using long-acting beta agonists for these asthmatic patients. They'd use them by themselves. They actually led to increased mortality. Not really sure why, but they started to see more of these asthmatic patients dying. So you won't use these alone. Occasionally, you might see this used for COPD by themselves. But we'll talk about some combination drugs in just a second that will, where you'll see some use of these long-acting beta-2 agonists. So things like formoterol, salmeterol, those are your most common ones. Okay, so again, when you're giving albuterol, these beta-2 agonists, you'll attack tachycardia, potentially hypotension. Think about that based on the beta-2 effects on the vasculature, which you just mentioned. See headache, dizziness, insomnia, also hyperglycemia due to some beta activation on the liver, right? So you're kind of getting these kind of sympathetic effects, and so you're going to see all these issues here. Okay. So next up, one of our main controller medications is going to be our inhaled corticosteroids. And so again, this list is very similar to what we saw with the nasal corticosteroids. So things like beclomethasone, budesonide, fluticasone, mometasone. Notice here they all have their counterparts, and this is why it's so easy to screw these up if you're not looking carefully, if you're not writing the label or the prescription appropriately, or not reading labels, you can get these mixed up. So we had cases where like Nasonex gets sent out for Asthmanex, or Flonase for Flovent. It's very easy to see how people can make those mistakes there. But again, these are all going to act very similarly. The doses are a little bit different amongst one another based on potency, but again, they all work almost equally as effectively as far from a clinical standpoint. So again, these are working very similar to what we saw with prednisone or dexamethasone. They're working kind of on the tip of the pyramid on preventing inflammation. But again, remember the time it takes for these to work? It takes a while, right? They're not going to kick in as quick as a beta-2 agonist, right? So again, these are going to take a while to work. It can take up to a few weeks before you really start to see the full-on effects, up to 8 weeks for really maximal effects. So the big thing here with these drugs is that you need to tell patients they have to take them every single day. They miss them, it's not going to work very well. In some patients, you'll start them on these meds and they're like, oh, I feel much better. I don't have to use my my albuterol inhaler anymore, and they stop taking it. And guess what? Comes right back to where it was before. So again, they have to take these. Are going to be potentially lifelong medications depending on the particular type of asthma they happen to have. Now, as far as anti-inflammatory or adverse reactions are going to go, you can have a risk for seeing oral candidiasis or thrush. Why do you think that is? Yeah, you get a localized depression of the immune system right there in the back of the throat. Because again, when you're inhaling things, does everything go directly into the lungs? Not necessarily, right? So if you're inhaling, some of it ends up in the back of the throat, some of it ends up in the stomach. You want to get most of it if you can. We'll talk about inhaler technique a little bit later, how you can maximize that. But the big thing is that you're always going to get some drug that's not going to reach the intended site. So you see a local depression of the immune system, and so you end up seeing a risk for thrush developing here, right? So the thing we recommend to patients whenever they're using one of these inhaled corticosteroids, you always wash out your mouth after using it, okay? So you act like you're saying a bad word and just wash out your mouth and just be done with it, right? That's a very common side effect you worry about with that. There's also some risk that people worry about, may suppress growth in children with really high doses. Clinically, that's not really a big concern. And then also maybe for patients who already have a depressed immune system to begin with, there is some systemic risk theoretically of depressing even further, but really not a big deal. The thrush thing is really the biggest side effect you're going to run into with these drugs.
So, because this is more local, I guess you wouldn't see a lot of like the fluid retention and like the tendon rupture.
Yeah, you don't really see the same systemic side effects you do like you would for like a systemic corticosteroid, right? So it really should be kind of localized to the effects of the lung. And again, if you're driving the dose up super high, could you potentially get enough systemic absorption to be a problem? Theoretically, yeah, but clinically we don't really see that come up.
Because of its location, could it maybe still cause like the glaucoma and cataracts?
No, because it has to, once it's crossing, like say, like even like the mucosa on the oral pharynx, like it still has to get into the bloodstream and then circulate around. So the concentrations you would get wouldn't be very high. Now, if you accidentally dumped it out in your eye on accident, maybe that might be a problem, but typically clinically not really a big issue. Yeah, which is why we like to use them, right? I could use this safely in a glaucoma patient and not worry about. And what's interesting, I was telling another student about this previously, and they were like, "Oh, my grandma was asthmatic, and she used to take prednisone every single day for like 20 years." Before these were actually available, and she talks about like the osteoporosis she's having to deal with now, those other kind of health problems that could be related back to chronic prednisone usage. So these are really kind of a very nice thing that we can control the asthma without the side effects of systemic corticosteroids.
Is that supposed to be inhibit anti-inflammatory or just anti-inflammatory?
It should be inhibit the inflammatory cascade. Thank you for, because that's a double negative, and that would be causing inflammation. That's not the case. So I will correct that. Thank you for pointing that out. All right. So most often what you'll see a lot of asthmatic patients being put on are a combination of a long-acting beta-2 agonist plus a corticosteroid. So the nice benefit here by using something like formoterol and budesonide, which is like Symbicort, which you see pretty frequently, Advair is another common one. By combining these two, you get the quicker onset of a beta-2 agonist. It's going to be lasting, say, 12 hours throughout most of the day. And then you also have the inhaled corticosteroids, which is going to be working kind of more long-term. So these are really effective combination drugs, and this is probably what most asthmatic patients end up being put on in a lot of cases, depending on insurance and things like that. The steroids themselves tend to be a little bit cheaper, but if the patient's insurance will cover it, these are going to be really, really effective drugs. I'm a personal fan of Advair. That was the drug I got put on eventually that led me to never have to actually carry my inhaler around anymore. So it was a very nice kind of benefit from that, because I had kind of the long-acting beta-2 agonist effects plus inhaled corticosteroid, right? So I'll talk about my asthma meds all day long, but I didn't talk about any of my infectious disease meds probably for good purpose. Just kidding. Okay. So moving on from that, the next thing are going to be our leukotriene modifiers. These are also going to be kind of controller medications. These are not going to be quick fixes for an acute asthma exacerbation, right? So leukotriene antagonists, these are going to be ones that block the leukotriene receptors specifically. So we have zafirleucas and monteleucas, or singular. This is going to be the most common. I'll talk about why you don't want to use zafirleucas in just a second, but monteleucas is our go-to leukotriene antagonist. And basically they're blocking this LTD4 receptor. Specifically, they're blocking that one. And again, this one is mediating inflammation, bronchial constriction, mucus secretion. So if you block that effect, you might have lipoxygenase still being overactive and still producing a lot of leukotrienes, but this prevents it from actually kicking in because it never reaches the receptor, which is great. The reason why we don't use that for leukas is due to CYP interactions. Blocks CYP2C9, 3A4. Monteleucas doesn't do that. So basically, I've never actually seen zafirleucas used clinically, but I've seen a ton of monteleucas being used for management of kind of chronic asthma for a lot of patients. Okay, this is also effective in the aspirin-induced asthma I mentioned before. Remember that pathway where you're shunting, if you're blocking cyclooxygenase, you shunt that pathway, arachidonic acid over the lipoxygenase pathway. This is effective for that. So you could potentially use this if someone had aspirin hypersensitivity that was mediated by that. You could potentially use this drug to prevent that from occurring. Okay, make sense? All right. There's another drug. This is another one very seldom used. If they were kind of failing other therapies, this is kind of be like kind of a third, fourth string kind of drug. There's one called Xyluten or Zyflo, and this is actually directly inhibiting that 5-lipoxygenase enzyme. So think about this kind of being like an NSAID, but for the other side of that pathway. So this one not very good. It's mainly used IV, and it causes a lot of flu-like syndrome, drowsiness, can elevate your hepatic enzymes, inhibits CYP1A2, 3A4. Just not a really good drug. So again, third, fourth line drug. If they failed other stuff, this is where we can kind of maybe jump back to if needed. So again, kind of talked about that pathway already. Right, just other things you might see if you had a patient had evidence of liver dysfunction, obviously jaundice, nausea, vomiting, abdominal pain, all that kind of stuff. Pruritus being another one, do that kind of hyperbilirubinemia. So really for side effects for leukotriene modifiers, not a ton. These are actually very well tolerated for the most part. They're also pretty weak as far as efficacy goes. Some people do really well with it, but a lot of patients, they tend to not really have as strong enough effects as you would see if you had inhaled corticosteroid plus a long-acting beta agonist. So again, a lot of patients do very well with these, though, so they couldn't tolerate other things. Leukotriene receptor antagonists might be a decent option for them, but not a ton of side effects. Again, these are pretty rare for the most part. Okay, so some other things we can do to hopefully either remove the trigger or possibly the antigen is by stabilizing the mast cells. Again, these are also limited in their use. I just kind of mentioned them here just for completeness sake. We have things like cromolyn, metacromyl. Some of these we saw previously in the ENT section. Again, these would be inhaled drugs that would be taken basically as a controller med. You take it before the acute exacerbation because, again, once the mast cells degranulate, you can't really do anything about it at that point. So again, unknown mechanism, but again, if you ever see a patient on them, just know that's what it's being used for. Obviously, I'm not focusing a lot of time on these particular drugs here, so I'm probably not going to ask a ton of questions on them, but things I spend a lot of time on, like inhaled corticosteroids, short-acting beta agonists, that's probably more likely testable material, right? But again, these mast cell stabilizers are very similar to what we saw with the ophthalmic stuff. They take a while to work. Again, they have to be used chronically. If patients are not using them appropriately, then they're going to end up seeing those reactions because the mast cells are not really stabilized effectively. Again, nothing really specific as far as side effects go for here. Again, mostly well tolerated, but again, relatively ineffective compared to some of the other drugs we've already mentioned. What I want to talk about is this drug called omalizumab. Now, have we covered any MAB drugs before? Oh, Neurocloud. Okay, so what is a MAB drug? What does that mean? Monoclonal antibody. So anytime you see MAB on the end of a drug name, it means it's a monoclonal antibody. That means that it's a protein. Can you take protein-based meds orally? Why not? Stomach breaks them down, right? Just like it does any other protein you would take, from a steak to a hamburger to omalizumab. Your stomach will break down these proteins. So you can't. These all have to be injectable drugs. Also, anytime you're injecting foreign protein into the body, what is a big risk? anaphylaxis, allergy, hypersensitivity. So this is a class-wide effect. So it doesn't matter if we're talking about asthma med, that's a monoclonal antibody. There's a ton of cancer drugs that are monoclonal antibodies, a lot of rheumatologic drugs. This will come up again and again, and just know this is a drug class-wide effect where you can see hypersensitivity, and again, because it is a foreign protein, it has to be an injectable. And also, what do you think that means for the cost? Yeah, because these are like recombinant, like we are making these are custom designed proteins. They are very, very expensive, several thousands and thousands and thousands of dollars per year to use. But they can be quite powerful because they are very specific. Because again, what does a monoclonal antibody do for us? Basically, it can target a specific type of protein or an antigen, or in this case, this will actually be targeting a specific type of antibody. And so in this case, we're designing an antibody that's going to go after IgE. So it's actually going to bind up IgE. Again, it's a recombinant DNA form, so again, it's very difficult to make, which explains how expensive it is. But it's going to be against this IgE antibody, right? Binding that up, you kind of stop that the IgE from actually binding to the mast cells to ever start them up in their inflammatory cascade in the first place. So again, very, very effective for limiting that, but it's going to require going in to get infusions of the drug or injections of the drug, usually at like an infusion center or the clinic, things like that. They typically have to be given less frequently than a lot of other drugs. So these are usually drugs that you give maybe every 4 weeks, every 6 weeks, depending on the dose. So that's the other benefit of the monoclonal antibodies. Even if you have to go in for it, it's usually pretty infrequent that you have to do that. But of course, there is some risk for anaphylaxis, as I mentioned. Some people have some GI disturbances associated with this, and then also there is some risk people are concerned about with secondary malignancies. I'm not really sure the mechanism for that one, but it is a potential risk. So like for instance, we have a lot of kids that are coming to our asthma clinic who strictly just come in for their Xolair. Xolair is the brand name here. And so they come in every 2 to 4 weeks or so. This one happens to be given sub-Q. Again, some of them can be sub-Q, some have to be IV depending on the drug. But they just are not well controlled on really anything else. Even they might be on inhaled corticosteroids and be on the rescue inhaler. They still have to use this in order to make sure they have make sure they have really just tight control on that whole inflammatory cascade and prevent it from occurring in the first place. The other big thing is you always want to watch patients the first time you give this drug in the clinic for at least an hour or so, because you want to make sure they're not going to have a reaction to it. Kind of similar to what you would do if like someone got a vaccine or something. You might watch them for a few minutes just to make sure they don't have any issues with it. Okay, and there is some risk though that people might, with repeat administrations, develop hypersensitivity to it. So just because they get it right the first time and they have no problems doesn't mean you might have subsequent problems. Okay, so again, looking at anti-IgE, this is Xolair side effects. Again, you can see some allergic type reactions, injection site pain, some bruising, but other than that, very well tolerated for the most part as long as they don't have a reaction to it. Okay, this is going to be our oldest group of drugs we have here. These are called our methylxanthines, which includes things like theobromine you find in chocolate, includes caffeine, includes theophylline, which is the main one we're going to talk about here. It's very old school drugs. You occasionally will see patients who are very difficult to control asthma still on it. You occasionally will see patients with COPD being on this. And so they're less effective than long-acting bronchodilators. They're less well tolerated, meaning there's a lot of side effects associated with them. And you also see we have a narrow therapeutic index. So seeing a narrow therapeutic index, what does that mean? We should do therapeutic drug monitoring. So you have to do drug levels on this now to make sure patients are not getting their levels too high or too low to cause toxicity or to lose effectiveness, essentially. Now, these drugs, you can see things like arrhythmias happen here. You can see convulsions, a lot of altered mental status if the levels get up too high. I'll never forget this one patient we had when I was in fellowship. She was this little old lady who'd been treated for asthma. She was probably like 87, coming in from the nursing home. She had been, the really old school physician who had her on theophylline. She'd probably been on it for 30 years. And then, of course, no one's watching her renal function. Happens to be renally eliminated. And she comes in this status epilepticus. Does anyone know what that is? Uncontrolled, prolonged seizures. You cannot break it and get her back to a normal mental status. We're giving her Ativan after Ativan after Ativan. Just basically had to end up intubating her. We eventually get her to a point where we've given her so much drug to help activate GABA. Remember GABA being that inhibitory neurotransmitter. Finally stopped seizing, at least on the outside. Put her up to an EEG, and she was still in this what we call non-convulsive status epilepticus. She ended up dying, unfortunately. But you have to be really, really careful with theophylline if you're ever going to use it, because it can be very toxic in patients who don't clear it very well. Anyway, but for you guys, you'll probably never ever use it, and it'll be like, what was that one drug he talked about that one time? And you'll never see it again. However, though, occasionally, similar to status epilepticus, is there a version of that for asthma? status asthmaticus. Yeah, so status asthmaticus, which is kind of a similar thing. We're basically just having really severe, kind of unrelenting kind of asthma exacerbation. But this is, I've actually seen this a few times. Some of our pediatric ICU docs would actually utilize the IV form of theophylline called aminophylline, and actually utilize that if they were really running out of other options that they could use for that patient. So again, a little bit different pathway when you're treating that, but yeah, it's definitely an interesting drug. Again, you probably won't ever use it in your careers, but again, we mentioned it here for completeness sake, in case you ever do see someone on it. Okay. So I mentioned theophylline. You may see some limited use in COPD. It's probably the more common place you're going to see that. But one of the things it's going to help us to do is it can help to inhibit phosphodiesterase. So you guys remember phosphodiesterase? Don't remember what that did? Remember how cyclic GMP is important for causing smooth muscle constriction, and if you can inhibit that breakdown, I'm sorry, cyclic GMP is actually causing smooth muscle relaxation. If you can inhibit that by preventing breakdown by giving a phosphodiesterase inhibitor. You remember we were talking about our erectile dysfunction meds? Remember how I said I give little girls Viagra?
Yeah.
Right? That's because it can actually help with the lungs, because it actually helps to vasodilate. Those vessels in the lung can actually help with these kind of VQ mismatches. If you guys have ever heard that term, you'll talk about it later on. But so it can help to increase cyclic AMP, cyclic GMP, help to relax some of that smooth muscle in the airways. And it also works to inhibit adenosine. You probably heard adenosine in your EKG lecture. Did you talk about it? Yeah, so you can also see adenosine, just a natural product your body makes. It can help to, this can also be useful in helping kind of reversing the asthmatic effects, and it has some anti-inflammatory effects. So in theory, it's a really good drug, but the toxicity just makes it where it's not even worth trying in a lot of cases. A lot of our drugs nowadays we have are just either just as effective or more so, and are a lot better tolerated. Okay, so again, you can see some gastric acid. You can end up seeing diuretic effects, smooth muscle relaxant. Again, this is something we'd be measuring levels for. So again, you can see excess CNS stimulations like causing seizures and convulsions above 20 micrograms per ml. Arrhythmia is another possibility due to those adenosine effects. So again, not a drug we like to use very often. I'm not going to ask on the levels specifically, but just know that some of the toxicities associated with it. Okay. Again, I won't cover it. Just know it's renally eliminated. You got to watch renal function, otherwise they're going to accumulate the drug like crazy, and then you can end up seeing that seizure and whatnot. Okay, so the other thing we can use potentially is either a short-acting or kind of a long-acting controller medication. Are going to be anticholinergics. And again, these are going to be antimuscarinics. They're blocking the effects of acetylcholine from activating those muscarinic receptors, which will help us to lead to some bronchodilation. The short-acting one we're going to use is a drug called ipratropium, which is called Atrovent. So if you ever hear someone coming in getting albuterol and Atrovent for like an asthma exacerbation, it's a common mixing of drugs we'll use in the for acute asthma exacerbations. We'll give them both Beta2 Agonists and an anticholinergic to try to get some synergy there. There's also a long-acting form where you're going to see this only for COPD, which we'll talk about a little bit later on. But this is called tiotropium or Spiriva, right? I think I don't watch TV that often. Usually, I'm one of those cord-cutting type people. But whenever I go to my mom's house, I'm always like just completely flabbergasted by the number of like drug commercials that are out there. And I always see a ton of COPD commercials. So usually it's talking about Spiriva, or it's talking about usually like inhaled corticosteroid, long-acting beta-2 agonist. You know, if you guys, the rare occasion you guys get to watch TV when you're not studying, try turning on the TV. You'll probably see at least a few of these meds pop up here and there. Or at least when you see them, you'll be like, oh, I know what he's talking about now. And be like, I don't know what he's talking about at all. Anyway, so anticholinergic side effects. If you're to get too much of this drug, we already kind of talked about these previously in the physiology course. But again, we have this mnemonic that we use to remember our anticholinergic effects. And it's just the opposite of what we'd expect to see with if you had cholinergic activation. So we use this mnemonic called blind as a bat. So potentially you've got a lot of this. You can see blurry vision, mydriasis, mad as a hatter. You can see potential hallucinations. And again, these are things you could also see with like our antihistamines, like the H1 blockers, that first generation ones we talked about previously. They get flushing, so they get red as a beet. Hyperthermia, they're hot as Hades, and then dry as a bone, so things like dry mouth, and potentially tachycardia as well is kind of another common side effect with that. Okay, so just be aware those are kind of side effects you can see with the inhaled forms. Though again, you're limiting a lot of that systemic effects for the most part, so you don't really see a ton of this happening here. You may see a little bit of increase in heart rate, but again, maybe do the albuterol that you're given as well, right? So it could be a combination of things. So again, with our oral corticosteroids, again, these can be very useful for kind of short course, kind of pulse therapy, as we'll call it. We're using it for, say, 5 days or so, like, say, 3 to 5 days worth of therapy. And again, these are working very similar to the inhaled corticosteroids, just more powerful, more quick acting, more systemic. The most common ones we're going to use include prednisone, prednisolone, which is just the oral liquid formulation of prednisone. There's methylprednisolone. This is good because this is a parenteral form. I can either give this intramuscularly or IV, depending on how severe the asthma exacerbation is. And again, if they're so bad they're not really able to tolerate oral meds because they're sitting there in the tripoding and not really breathing that well, then I can potentially give them an IV form instead, which can be beneficial. And then dexamethasone could also be either oral or parenteral as well. So it's good to know you have some options there. These are good for kind of severe acute exacerbations where I need to treat them for a few days with this to try to get them over that inflammatory hump, both the early and the late phase of that reaction, and then get them back down to baseline. Again, we talked a lot about systemic corticosteroid effects. You can see adrenal suppression, growth suppression. Again, this is more with kind of long-term dosing. So again, if you had them on it for more than a week, but again, most of the time this is like 5 days worth. So for most patients, it's not going to be a big issue here. Do you guys remember when you wanted to taper corticosteroid therapy? Greater than 5 days, yeah. So if it's just 5 days, not a problem. If it's greater than that, you generally want to. Now, if you wrote for, like, say, like a Medrol dose pack, that already includes the taper already built into it. So some of them will already have that kind of built into the dosage form already. So using these drugs is kind of a stepwise approach, right? Very similar to what we saw with like acne, where you start with kind of the easiest meds first, and then you kind of work your way up to more either toxic drugs or ones that are going to be more kind of labor intensive in order to get on board. So obviously, with the step one, someone who's maybe just intermittent asthma, every once in a while they need take a hit. Essentially, that's what I always say. Take a hit of my inhaler, or if they have like exercise induced, if it's very like clear, very very predictable, just a short acting beta agonist as needed is fine, right? So you just write for say 2 puffs every 4 to 6 hours is needed for wheezing, cough, then you're good to go, right? So that can be all you need for some patients. Once you start to get up in this more persistent asthma, right, this is when you need to start considering daily therapy. You need to start considering a way to control these symptoms in the long term to prevent them from having to use their short-acting drug all the time, right? The most inhalers come with like a 200 dose counter on it. It'd be surprised if you have really uncontrolled asthma how quickly you can run through that. And that can be a really important trigger too. Is if your patients, say you write for your patients a long-acting beta agonist and an inhaled corticosteroid and a short-acting beta agonist as needed, and all of a sudden they call up and they say, hey, I need a refill on that albuterol inhaler. And you're like, okay, well, do you need a refill on the other one too? Like, nope, just the albuterol inhaler. And it's only been like, a month or two. That's giving you a sign that, hey, these patients are not well controlled. We need to figure out what's going on. Either they're not compliant or the dose is not right or whatever it happens to be. So again, keep an eye on these short-acting beta agonists and how often they're refilling it, because that's a big component there, okay? Anyway, when you start off with this step 2, this is where you're going to start to think a low-dose inhaled corticosteroid. This can be by itself. Potentially, you could put it in combination with a long-acting beta agonist. Kind of plus or minus, not really going to see much of a difference there. It could be cheaper, though, to put them on just an inhaled corticosteroid by itself. That could be one option, okay? Again, I'm not going to worry too much about utilizing mast cell stabilizer or theophylline at this point. I would probably just worry about the inhaled corticosteroid. That's the key component there for control of therapy for the long term, okay? And it's going to take a while to kick in. You need to educate them on that to say, hey, their asthma symptoms may not improve immediately. It may take a few weeks, okay? As you start to go up the pathway, they're less well controlled, or say they're not really well controlled in this step 2. Again, we're using for sure an inhaled corticosteroid plus a long-acting beta agonist, or potentially you're starting to up your dose on your steroid, right? So it just depends on what they can tolerate, depends on what their insurance coverage is and all of that. Okay. As you start to go up, you're going to start to see more higher doses of inhaled corticosteroids. This is where you can start to think about things like leukotriene receptor antagonists. Probably even do it in step 3 potentially. Add on, say, montelukast for them to take, say, every evening to help control those symptoms. And as I get to higher and higher dose steroids, this is where you want to start thinking about things like omalizumab or that Xolair to help control the symptoms. So again, most of your patients are never going to get to step 4, 5, and 6, but just think about, okay, this med didn't work. Let me maximize my dose. If that's still not working, then what else can I add on, right? They're always going to have the short-acting beta agonist as a PRN med, and then they're always going to have some kind of controller medication on board as well for persistent symptoms. Okay. Notice here, ipratropium doesn't come up. That's really going to be more on the inpatient side, or like in the urgent care in the hospital setting when patients are coming in for like an acute exacerbation. We typically do not prescribe ipratropium on the outpatient side. It's less common than you might think. Okay. Does that make sense? So again, if I had a patient, like a case on a test question came up and said, hey, your patient, has got this moderate persistent asthma, they're taking, fluticasone and salmeterol, and they're still having to wake up, a couple times a night to use their inhaler, and, they, still having a lot of coughing, wheezing fits, and things like that throughout the day. What would be the next med to add on? And so you kind of evaluate your stuff. You say, well, maybe they haven't tried a leukotriene receptor antagonist. Let me try adding that on, or perhaps using some other type of therapy, right? So always consider that. What's kind of the next best drug for your patient if this does not work, okay? Okay, I'm just going to finish up this section on asthma real quick. And okay, so anyway, anyone know what a spacer is, or a valve holding chamber? For the kitties, that could be one reason why we use it for the kitties. Basically, and do I have a picture in a later slide? I do. I'll show you that in a second. Then, basically, what it basically is going to be this big plastic tube that is designed for you to squirt the inhaler into, and that will hold the dose essentially for you until the patient can breathe it in on their own. So why is that good for kids? Coordination is huge, right? So it's very, very difficult for very elderly patients or for kids to coordinate between pressing the inhaler for a meter dose inhaler and actually inhaling it and getting the dose in, right? Because again, I'll talk about the technique in a second, but coordination is important. And a lot of times, it could be that patients are trying to be compliant with the meds, but if the technique is poor, they're not going to get a whole lot of dose where they need it to go, which is in the lungs. So they're going to either end up on their tongue or in the back of the throat, or it's going to end up all in the stomach, okay? So they're kind of one-way valves that don't allow the patient to exhale into the device, but they allow for the inhalation of the drug that's sitting there. So again, it helps to also retain some of the larger particles. So again, particle size is really important as well, because too heavy of a particle is just going to go down to the GI tract. Too light of a particle, the patient may actually breathe back out when they exhale. So you need to kind of have the Goldilocks particle size, essentially, where you're going to be inhaling it. It's going to go right down into the lungs. Chambers help with that. So this would be an example of a meter dose inhaler, right? So again, notice here that this is all propellant based. So the patient does not have to breathe in for the thing to work. It already has a propellant in it. And so again, a lot of the manufacturers had to switch over to using a different kind of propellant because they're worried about the ozone. Although I doubt all the asthmatics in the world using their inhaler continuously would actually cause any problems with the ozone. Probably cows are probably a lot bigger component of that. But regardless, they switched them over, and then all of a sudden they had brand new patents, and they could make a whole lot more money on brand name Ventolin. Anyway, so big thing here is to make sure that the patients take off the cap first, right? So it's kind of like a camera. It doesn't work with the cap still on the lens. Shake it up, because these are going to be typically suspensions where, or if it is a suspension, you want to make sure you shake it up so that way the drug and the propellant get mixed up together. That way you don't have any layering effects that happen there. And it may need to be primed. So the first time the patient uses the inhaler, have them squirt a few doses through, usually 3 or 4, and that will make sure that when they inhale it, they're actually getting full drug and not just getting empty air, essentially. And then they'll breathe out all the way, they'll exhale, and then they will hold the inhaler kind of as shown. Here's just a few different varieties here. And so basically they're either it can be in the mouth, it can be kind of away. As long as it's pretty close, you don't want them like to hold it out here and try to get it. But as long as it's relatively closer in the mouth, you should be good to go. You laugh at this stuff, but you'd be surprised what patients will do if not given explicit instruction. Even if they get explicit instruction, they'll do some goofy stuff. So basically what you want the patients to do is before they press the button, they want to start inhaling in, right, slowly. You don't want to go, but it can be. And as they're breathing in, then you want them to press down on the canister, right? That will expel the drug, and that way you've already started a nice airflow going down into the lungs, right? You're not starting kind of from zero. You're starting with the already having kind of a nice airflow that will allow the particles to travel down into the lungs. You want them to go ahead and breathe that in, inhale deep, and hold it for at least 10 seconds, right? So 10 seconds is a good number. If you can hold it for longer than that, that's great. And then also, you don't want them to use 2 squirts at one time, right? Because why do you think that wouldn't be good? Well, if you think about it, like, their smooth muscle is constricted, like they're preventing airflow from coming in. So they get one dose in, starts to open up some of that smooth muscle. If you give it a few seconds or even a minute or two, the nice thing is that drug, the next dose can go even deeper, right? So you penetrate even deeper and be more effective. So I tell them at least wait a minute or two between doses, 15 to 30 seconds at a minimum in order to make sure that first dose kicks in, and then the second one can be even more effective than the first, okay? Again, some patients may not be able to hold their breath for 10 seconds. That's okay, as long as they can hold it is going to be effective for them. Okay. So again, obviously, asthma, it's a chronic disease. You need to make sure that if they're having persistent symptoms, long-term medications need to be prescribed. So it's, again, important when I'm evaluating, a patient only has exercise-induced asthma. Do they need an inhaled corticosteroid? No, they probably just need a short-acting beta agonist as needed when they're going to exercise, right? So think about those kind of patient considerations. Albuterol is only going to be for short-term relief for an acute exacerbation. And again, if they can, keep a diary, know what their triggers are. If they can avoid them, that's all going to be for the better, okay? Any questions from the first half? I'm going to try to finish this up and then go into cardio stuff if I have time, which I think I will, which is fantastic. So anyway, moving on, speaking more about status asthmaticus, as we kind of mentioned this. So again, this is a medical emergency. These are these acute exacerbations that basically are kind of unresponsive, excuse me, to initial bronchodilator therapy. So the algorithm, and which you'll see here, is going to be a little bit different than what we're kind of talking about for like a normal acute exacerbation. Patient comes in, they get albuterol, they get ipratropium as an anticholinergic, and then they usually will get like an oral steroid like prednisone or dexamethasone or something like that. This is going to be much more kind of invasive, much more severe, because again, this is a very, very life-threatening potentially reaction here. So again, we'll use what we call continuous albuterol. Basically, they're getting just a ton of albuterol nebulized per hour. They can be anywhere from 5 to 20 milligrams. You get quite a bit of it. They're just breathing continuously. And again, the nice thing about using a nebulizer, especially for kids, is that you can try to get a mask on. The mask can be the hard part, but again, they're just passively breathing in. So even if they're screaming and trying to fight you, like they're still breathing it in. Again, the more tachypnic they are, the more drug they should be delivering theoretically. You're also going to use IV steroids. So this will be things like methylprednisolone is the most common one they're going to use here. And then also what's kind of interesting is we have magnesium. So why do you think magnesium would be used to treat an asthma attack? It does bronchodilate. How does it do that? Interesting. So magnesium, we'll talk about when we get to the cardiology stuff. We'll talk about calcium channel blockers, and calcium. Like we mentioned, calcium is really important for causing smooth muscle constriction. Right? We've seen those kind of pictures before. Magnesium kind of acts like the body's natural calcium channel blocker, where you're kind of helping to cause smooth muscle relaxation by blocking kind of this calcium influx, essentially. So we give magnesium as a bolus, and then we'll run it as a continuous infusion afterwards. And so it helps to relax that smooth muscle around the airway, helps them to breathe a little bit better. The other side effect you might imagine, though, is what would it do to the vasculature? Dilate it. So you see hypotension, right? Hypotension can be another big thing you can see with large doses of magnesium given very quickly, which is also important. Does anyone know what you give to a pregnant woman who is having very severe hypertension, possibly even seizures from that, called eclampsia? You give them magnesium. Yeah, you give them huge doses of magnesium because it acts as a smooth muscle relaxer and it can help with the blood pressure, right? So again, we're using the drug for different disease states, very different disease states, but with similar purposes here as a smooth muscle relaxer. So we'll give that. We usually give them a bolus of fluids along with it to help make sure that they are they don't get too hypotensive. And then what's interesting is that at a certain point you have to consider intubating these patients because again, they're not going to be able to oxygenate on their own. And one of the problems they run into is the patients will tire out eventually. These muscles will eventually tire and they won't be able to support themselves really, and so you need to start breathing for them essentially. And so what we can actually use at that point is a drug called ketamine. We've talked about ketamine before, right? One of my favorite drugs ever because it's a really good sedative. The other thing it does, though, is it actually works as a bronchodilator. It's one of kind of the unintended effects of it because it works to raise blood pressure, raises heart rate because it helps to release things like epinephrine, norepinephrine, which will still activate those beta receptors that we're talking about. So it acts as a bronchodilator. It helps them to, it doesn't really hit your respiratory drive, so it's not a respiratory depressant, which is good. But if you need to sedate someone while they're intubated and they're having an asthma attack, ketamine's a drug to go with. And it's really, really cool to be able to give them something bronchodilatory and also knocks them out at the same time, so that way the vent can do its work essentially. Now you want to be careful with adverse reactions to ketamine with adult patients. One of the big things we see is called emergence phenomenon. This is why we like to use ketamine more in kids because essentially what you see is that patients can have a very bad trip, right? They call it going down the K-hole essentially, where when they come out of it, they are they can have hallucinations, they can become very agitated, they become very difficult to work with and become violent in some cases. And so typically adult patients I tend to see if they have a little bit more psychological baggage along with them, they tend to be more likely to have these really bad reactions. Little kids is great because you can be like, just think about going to Disneyland. They wake up and they've been hanging out with Mickey for the past couple hours, they're set. Adults are like, no, I hung out with Mickey, but he had a butcher knife and he was chasing me through Disneyland. Like it gets weird with ketamine. So anyway, you have to be careful with that. Also, you can see some nausea, vomiting. I mentioned the hypertension, tachycardia could be worse than that potentially if the patient already has that going on. So anyway, that would be a kind of a unique setting where you use ketamine as a sedative and a bronchodilator. The other thing is you may consider using aminophylline, which I mentioned is that IV form of theophylline. Again, this would be a very last line kind of therapy for these patients, but occasionally you may sometimes you have to do what you have to do. All right. Something I learned interesting. So have you guys ever heard of shallow water blackout? What is that?
You usually see it when the swimmers are holding their breaths for long periods of time, and then they pretty much just go lifeless in the water.
Yeah, it's real. I saw a picture of this like kid who had died from it, and it was like, what the heck is shallow water blackout? I thought it was really, really interesting from a physiology standpoint. Basically, swimmers, just as you mentioned, they end up hyperventilating, or if they try to hold their breath for too long. Essentially, what happens is when you hyperventilate, what does your CO2 levels typically do? They typically decrease. You're blowing off a lot of CO2. The goal is for these patients or these people, they're trying to get as much oxygen into the system as possible. So there's a lot of dead space in the respiratory tract. They try to blow out all that CO2 to try to get as much oxygen in as possible so they can hold their breath for longer. So typically what they end up doing is they have their CO2 levels drop. They go swimming under the water for a while. They're not breathing in. So their body needs oxygen. But we mentioned before, what is one of the strongest drives of your respiratory center? Carbon dioxide, right? It's not oxygen, it's carbon dioxide is the bigger push there. So the patients, either they're being deprived of oxygen, but their CO2 levels are down. So even though they're starting to climb a little bit, they're not really at that point where they would actually trigger a breath. So basically patients get to a point where they don't breathe, they don't even know they need to breathe, and they just pass out underneath the water and drown. So I thought it was like, wow, that's actually kind of crazy if you think about it from the physiology standpoint, why these patients are just basically blacking out underwater for no good reason. It's basically due to the fact they hyperventilated and are deprived of oxygen. So little TIL for you guys, if you ever, it's a little depressing, but it's kind of interesting from a respiratory standpoint. Anywho, moving on, talking about chronic obstructive pulmonary disease, or COPD. You guys didn't mention you have a test tomorrow. I thought you guys would be experts on this already, if the test, right? Anywho.
We can go study.
Yeah, once you go study, yeah. Anyway, I'll try to get you guys out here whenever I can. All right, so anyway, so we know COPD is this chronic inflammation. What's the #1 cause of COPD? Smoking that tobacco, yeah. So again, you're inflaming the airways, that lung parenchyma is starting to get destroyed. And again, this is generally not fully reversible. This is the big difference between asthma versus COPD, is this is not going to be reversible changes in that parenchyma that's been kind of destroyed. And again, accelerated decline in FEV1. What's the biggest genetic reason for COPD? Yeah, alpha-1 antitrypsin mutation. We can see kind of accelerated destruction of the lungs through that. Anyway, though, looking at this, feeling like your progression, so this kind of red line here is going to be FEV1 versus the blue lines, your symptomatology. You're going to see pretty well declining FEV1 as time goes on, as you destroy more of that kind of lung tissue, and then the symptoms obviously are going to become much more severe. And again, a lot of these are not going to be reversible. So we're going to try to deal with that inflammation, but there's only so much we can do for a lot of these patients. And again, ultimately, what might they need in order to survive? Sometimes you can see lung transplant being done for these patients. Pretty rare, I'd imagine. I don't work with a lot of those patients, but you could potentially even see that being done to actually get rid of the bad lungs and bring in some new ones. But again, if they're smoking all their lives, it's kind of hard to make that case. But probably someone had like a genetic reason for that, you might be more likely. Anywho, mentioned alpha-1 antitrypsin deficiency, even indoor air pollution. Like I'm sure people have seen really bad air pollution, especially like inner cities, downtown areas. Tends to be a lot worse. Just that chronic inhalation of these kind of irritating chemicals can lead to chronic damage. So anyway, this drug therapy, I'm sorry, my picture's not sized appropriately. But anyway, basically what we're going to do, we see all the same drugs here. So I'm only going to focus kind of on what the stepwise approach to treatment is going to be for these patients. But it's important to note the distinctions between how you treat asthma versus how you treat COPD, because the meds are a little different here, okay? So basically what we're going to do is, as you're doing kind of regular assessment, obviously we're going to focus on smoking cessation. We're going to talk about a few meds that will do that in just a few minutes here. And then also vaccines are going to be important. So we're going to talk about that. Basically you want to make sure they have their annual influenza up to date. Right, and then also we'll talk about the pneumococcal vaccines being very important as well. They tend to be more likely to see pneumococcal disease in these patients. That's why we want them vaccinated. So for symptomatic management, what we're going to do is we're going to start off with a short-acting beta agonist. So that's still going to be effective for these patients, right? So we're going to start off with one of those. And also we're going to consider adding on some long-acting inhaled bronchodilators. You can consider using just a long-acting beta agonist by itself. that would be appropriate in these patients, or you could use the combination with the inhaled corticosteroid plus a long-acting beta agonist. Okay, that would be totally fine. The other thing you can consider using is going to be an anticholinergic drug. So this is where that Spiriva comes into play, or that tiotropium I mentioned there. Spiriva is really kind of interesting from a, I guess not interesting, but from a tox standpoint, it actually comes as a little pill. It comes like a little capsule that goes into a special inhaler, has a button on it. You will press the button, and then it will pierce that little capsule. The powder will come out, and the patient can inhale that. I cannot tell you how many 70-year-old patients I had called in the poison center on the weekends I had to work there, saying, I just swallowed my Spiriva cap, so what am I going to do? Am I going to die? I said, no, you're not going to die. Just go ahead and take another capsule and make sure you breathe it in this time and not try to swallow it. But anyway, so again, patients need to be educated. They just look at another capsule and they just think, hey, I'm supposed to take this orally. You can see how they can actually goof that up and not get the therapy they actually need when they need it. Or if they try to put a different capsule in there or something, you have bad eyesight or bad memory. All these can be impairments for your older patients, right? So anyway, so you're looking at long-acting anticholinergics like tiotropium. You're looking at your long-acting beta-2 agonists as well, maybe some inhaled corticosteroids. All those are going to be effective here. And then at this point, you also can consider things like theophylline being utilized here. Again, if they're kind of unresponsive to kind of previous therapies. But really the big difference here is going to be that that long-acting anticholinergic. You really don't use Spiriva for asthmatic patients. You really only use it for COPD patients. The other thing, only use long-acting beta agonists by themselves for these guys and not for the asthmatic patients. Okay, really the big difference there. Obviously, pulmonary rehabilitation would be effective if they're candidates for that. And then you also are looking for treatment of hypoxemia. So obviously, they can be put on long-term oxygen, things like that. Also, if you're ever on oxygen at home, make sure the patients do not smoke around that or are around gas grills or gas stoves, because guess what happens? Oxygen tends to be pretty explosive, and I've seen several very severe burns come into the trauma center secondary to that. Someone had a gas stove, smoking a cigarette, oxygen hooked up, and boom. There's one crispy fried COPD patient. It was not good. I would not have wanted to survive what that guy actually went through. So make sure you educate patients appropriately. So how do you get patients to stop smoking? You tell them don't smoke, it's bad for you, right? They're going to stop? No, it's ineffective. That's not going to work, right? But we know smoking major contributor here, and about 15 to 20% of those smokers eventually will end up developing COPD, and probably about 85% of those cases that do develop are going to be due to smoking, at least in some degree. Obviously, the smoking cessation is going to be a very complex issue. There's a lot of psychological, social, physical manifestations here that are associated with this addiction. And so the goal is to try to use multiple modalities here, right? So I'm not going to get in deep on the kind of the cognitive behavioral stuff that you can do to work with these patients, but we will focus on the kind of the pharmacotherapy, how that can be a useful augmenter of cognitive behavioral therapy to try to get these patients off the smoking, right? We're going to be looking, again, I mentioned the effective programs are going to mix modalities here, so using pharmacologic intervention plus counseling. And again, they've seen that the more counseling they have, the more intensive it is, the more likely they are to stick with it and actually quit smoking. So again, this cannot be ignored here. It's not enough just to use drugs and hope for the best, right? So a few agents that we have here. What do you notice about some of these that are available? They're all nicotine based, right? So in one regard, we are just, because again, the major addictive component of cigarettes is nicotine. So we can replace that essentially, right? We can try to initiate sort of taper to where these patients will kind of just naturally lower their dose over time and eventually, hopefully, just come off of it completely. So that's going to be one modality. And we're also going to look at a few other drugs that are working via a little bit different mechanisms. So we have one called bupropion. Does anyone know where we use bupropion normally? Depression, yeah, depression's a big one. So again, depression, there's called Wellbutrin. Here, this is called Zyban. So it's a different brand name for a different indication. Guess what? More money. We also have this varenicline or Chantix. I'm sure anyone ever heard of Chantix before? Yeah, it's kind of another kind of big blockbuster kind of med where trying to get these patients off their smoking. So we'll talk more about those in just a minute. So bupropion usually comes with either a sustained release or an extended release. The dosing is a little bit different, whether it's once a day or twice a day. So make sure if patients are on this, you get a good idea of how often they're taking it, because you don't want to goof it up and mix one product with the other. You can screw up their dose pretty significantly. Essentially, though, what we're seeing here is that nicotine is going to indirectly activate this epinephrine and then also dopamine. Remember, what's the main neurotransmitter of the reward pathway, the mesolimbic pathway? Dopamine, right? Dopamine squirts are what we crave. That's when we have a juicy hamburger or we have a delicious craft beer or you have sex or whatever it happens to be, like you get a lot of dopamine squirts. And so nicotine does the same thing. Listen, it's like a squirt of dopamine. It's just like if you do a line of cocaine, like you get a squirt of dopamine. I don't know why this terminology is. Anyway.
You need to go back and watch the video.
Yeah, you guys can go watch the video. They're laughing at me or with me? I can't tell. Okay, so dopamine, very important for the reward pathway. But what bupropion is going to do is it actually prevents reuptake of dopamine. Because remember, our brain wants to be relatively conscientious of getting rid of some of these neurotransmitters. It likes to reuptake them and recycle them, right? It wants to be pretty frugal with their neurotransmitters. So what we can do is by giving a drug that blocks that reuptake, you basically kind of level out the amount of dopamine that's in the synapse, and you kind of help to level things out. So even if they are smoking, you're going to find that they don't really get the same kind of dopamine effect, and it kind of levels things out to where they don't really get those cravings so much. And again, if they're coming off the nicotine, they're getting less of those dopamine, I don't know what you might want to call them, outpourings or dopamine activations. But instead, you now have this kind of like leveled out amount of dopamine that's there in the synapse, and thus they don't get those kind of same intense kind of cravings, right? So we're actually starting to see some use of bupropion as well for things like overeating, right? Because again, overeating can be an addiction as well. So if you kind of prevent that nice flow of dopamine in relation to like a steak or something like or overeating, then that can be useful as well. So you're going to see bupropion used for several different things related to addiction. Here, where we can use it for nicotine addiction, even though it doesn't really affect nicotine itself, right? Also, we'll have some effects a little bit on norepinephrine. And when we get to talking about behavioral and the psych meds and stuff, we'll talk about how serotonin plays a role in some of the stuff as well. But again, a lot of these are working as reuptake inhibitors. So again, increasing levels in the synapse. So how we're going to use it for smoking, again, typically it's important to realize, like, can you use these drugs with cigarettes or not, right? Some of them you can use while still smoking. Some of them you do not want to use while smoking because it can lead to toxicity. This one, you can certainly use, the patient can still smoke and be on the bupropion. And because what we'll see with some of these psych meds, they take several weeks to work. A patient could start out on bupropion. They can be on it for a while they're still smoking, and then eventually kind of wean off of the cigarettes, and that's okay. They can be on both these medications until the bupropion kind of kicks in, right? People you want to avoid taking this are going to be ones that have seizure disorders. It can increase your risk for having a seizure if you're kind of prone to it. Patients who are taking MAOIs. You guys remember that enzyme monoamine oxidase is responsible for breaking down things like dopamine, norepinephrine, serotonin. It's an old school class of antidepressants we don't really use anymore, but if they were on something like this, you would end up having a reaction there. But think about, do you remember any antibiotics that had MAOI effects? It's a really good gram-positive killer. Yeah, linezolid, yeah, Zyvox. Zyvox has the same effect. So if you had a patient who came in for MRSA pneumonia or something, or an abscess, if I were to give them Zyvox and they were on bupropion and I would recontinue that, that's where you can run into issues, right? You have too much serotonin, too much dopamine, too much norepinephrine. You can end up seeing toxicity from that. So be careful with those kind of drugs. And if they're taking other agents that can affect things like norepinephrine, things like tricyclic antidepressants or venlafaxine that can, again, have kind of synergistic activity. So we'll talk more about those in the behavioral health section. Just know that anything that's going to be affecting levels of dopamine, norepinephrine, this can interact with bupropion, okay? So following that, we have nicotine replacement agents. So these are going to be things that will help to basically replace the nicotine that the patient is not intaking by themselves through smoking alone, right? So the goal here is to try to reduce that craving by directly stimulating the same receptors, same nicotinic receptors that nicotine would, and try to minimize that physical withdrawal, right? So you ever seen anyone who's ever tried to quit smoking? What are they like? They're kind of a pain to be around, right? They're really anxious, they're irritable, they're restless, they have insomnia, all this kind of different stuff. So again, they're not really pleasant people to be around when they're trying to come off of that. This helps to mitigate some of that and helps to replace some of that nice physiologic effect. The goal here is to try to titrate down off their dose over a period of time. This may be 6 weeks, could be 12 weeks, depends on how well the patient is tolerating that and just how dependent they were on it previously, right? Now, patches and gums are available over the counter. So again, it's important to make sure that patients aren't using multiple dosage forms at the same time because they can just get more nicotine than they might have been with smoking by itself. And then there's even like some inhaler type forms where the thing is actually shaped like a cigarette, and it actually helps with some of the physical component to it because some people are just used to having that physical motion of smoking. This helps to kind of replace that. So talk with your patient, see what works for them. But be careful if they have a cardiovascular history because again, nicotine is a cardiostimulant. You can end up seeing some risk for arrhythmias, hypertension if they get potentially too much, right? And the Chantix is kind of a cool one because this is a partial nicotine receptor agonist. So again, you wouldn't want to smoke while on nicotine replacement. This one's kind of interesting because it is a partial agonist for the nicotinic receptor. If this is binding up that receptor, nicotine can't really come along and occupy that receptor at the same time. So you could actually smoke and still be on Chantix at the same time and not really see toxicity because the Chantix is going to bind to it more tightly. Okay, so basically what you end up doing is that you're going to end up seeing that you start 1 week before your actual quit date with Chantix. You have them on it for that week, and then they quit cigarettes or whatever if it's dip or whatever happen to be on, and then you continue that for about 12 weeks or so. Okay, so again, if they happen to relapse and they start smoking again, that's okay, right? Because again, you have those receptors already being bound up by the Chantix, just kind of partially activating it. That's kind of the benefit there. The interesting thing are these neuropsychiatric events. So again, you may be like, great, I don't want to smoke anymore, but now I have like depression or I have suicidal ideations. So monitor your patients for that. Look for these changes over time. Check in a few weeks to see, are they having any kind of new thoughts of self-harm or anything like that. So just be aware of that. The other big thing is that you will get some crazy, crazy dreams while on Chantix. If you ever talk to someone who's been on it, they say they have the most vivid dreams they've ever had in their life while on this. So that could be another thing that maybe could be okay for some patients, maybe really, really terrifying for other ones, so they may not want to use that. Okay, so again, you kind of gauge your patient, decide which option might be best for them, whether it be bupropion, whether it be Chantix, whether it be a nicotine replacement. Okay. As far as immunizations go, we have a whole lecture on immunizations in Pharm 2, but it's really important to make sure they get their annual flu up to date, and they also should get their pneumococcal vaccine, especially if they're over 65. Definitely get that up to date, so that way you make sure that they are not going to be more susceptible to those particular pathogens. Okay, so any questions on that? Okay, we have about 20 minutes. Let's start up some cardiac stuff.